let's fire up with some questions, otherwise I'll have to ask the questions, which won't be good.
All right, so one that's just jumped into mind. There's a little bit of chat before about cognitive decline through the process of brain tumour, and particularly as you get towards the end of end of life, let's say. I'm kind of curious as to whether, should patients expect to see some level of cognitive decline, even in the absence of a real progression in the tumour, and so whether that's from the tumour itself, just having been there without it necessarily progressing, or from the treatments, so chemo, radio, whatever it is. I'm just kind of curious about that, something I've never really gotten across.
Right. Can you hear me?
Yes.
That's an important question, I think. I think it's very difficult to discern what the origin of cognitive function disturbances is in brain tumor patients, especially towards the end of life. They lead you for sure to the progressive disease, but also due to treatment effects that were given early on, like radiation, for example. But again, also other medication, supportive medication, painkillers, corticosteroids. So it may be very difficult to discern exactly what the cause is. But we do recognize in many patients there are cognitive problems.
Do you want to say anything, Ben? Anything to add? No, he doesn't.
We don't have anything additional to add.
Yeah. It's a hard one, the cognitive decline thing, I think, isn't it? And I think, for a lot of patients, we do see this, and it's part and parcel of what we see each day, but a lot depending on where the tumour is as well. I think some patients don't go through this so much, but things like fatigue, medications, treatment, the tumour, I don't think there's one thing that we can pinpoint. It's just an accumulation of a lot of things that can occur. Okay, any other questions?
In terms of the new research for the treatments, so currently, the AI, they are quite popular. I just want to know how the new research involves the AI. Thank you.
Yeah, I can probably speak to that. So I think there's two areas specifically where I know AI is being used a lot. One of those is in medical imaging. You may be aware, even in sort of standard clinical practice, not just in research, AI is being increasingly used in diagnosis for radiologists to make their diagnosis quicker, and in research being used to see if we can sort of see new avenues for treatments. One of the other areas that where AI is being used, and they're possibly even talking about this next door as we speak, is in medical research, and hopefully Matt should probably has a lot more to say about that. So certainly in sort of treatment-related organoids and choosing best treatments to try and speed up the process in the lab. But I'll defer to the scientists to speak about that.
Thanks, Ben. Yeah, I suppose AI only works for things that are known. So what we're using AI mostly for now is to integrate the multiple research platforms that we're simultaneously doing on each tumour. As you would understand, there's the genetic side of a tumour, which is where you get the changes in the genes that give rise to the disease. But then there's the contribution to the tumour by its surrounding cell types, and often those cell types are just normal brain cells. They might be normal neurons that are connecting nearby, or they might be the brain's resident immune cells, and they all crosstalk with the tumour. And what we're trying to do now is to use AI platforms to take all these different data sets and integrate the data set meaningful. So at the moment, it's a tool that doesn't really give us productive answers, but I'm sure in time, once we've learned to integrate all of the different knowledge bases, then it will become quite informative.
Yep.
Hi, thank you to all the speakers. As a clinician, I'm a neurosurgeon, and in the cold face in some of those personal experiences as well as delivering that research care. So every single speaker I really learned a lot from, so thank you. And my question is, from both your clinical aspects but also your personal aspects, I've never been taught how to tell a patient their clinical diagnosis. That's something that I've learned from experience. I'm sure everyone here has an opinion about that from their own experience as well. From the panellists, I've been taught to drip feed information, and patients sometimes are very frustrated by that. But of course, our first speaker said that knowledge is power, and perhaps giving patients and their families knowledge early on is really helpful. Any insights in that space to sort of help navigate a clinician who has to do this on a regular basis?
Well, thank you. From my perspective, I think I changed over the years in telling about a diagnosis to brain tumor patients from the start. For sure, some 30 years ago when I entered this area, the world looked differently and patients were not that much involved yet in all the knowledge that was there. There was no internet, there was hardly anything. So I think you told patients they had my baseline is always not to give false information to patients. So just to speak the truth, just to give them the full information, but no, not the full information from the start. You just explained part by part what was the problem, and trying to get in touch with these patients, because you didn't know the patient and the families, by talking to them to see what exactly did they want to know. There were patients who were not really willing to know exactly what was going on there, or the prognosis, for example, and the others were definitely very much looking to know, eager to know what exactly what's going on. But I think this has changed, so to speak, for the better, because patients are better informed. There's a lot of information. There's openness about the disease. The word cancer in the Netherlands was 30 years ago something difficult to pronounce, which is now, it's all open there, which is, I think, very good, and it makes it very easy to communicate with patients. I remember when I started, one of my teachers said, I am never going to lie to a patient, but I keep my worries before myself. So I'm not going to worry a patient about things that may happen in due time. But I think that really has changed. So I think, from my perspective, I try to be completely open to patients about the diagnosis as all that we know, and if patients are asking for prognosis or anything, we have to explain this for sure, but to really be careful to explain that if you talk on prognosis, it's something that's based on large data sets, and it's never about an individual. And I think if you're not open, if you're not trying to really to give the full picture, it will work against the trust that you have with your patients and their families. And that's something that's really very important. Well, that's my perspective.
Marina, I'm hoping you'll have something to say here as well, but that's very eloquently put by Professor Taphorn. I guess the only thing I wanted to add is that learning how to break bad news is a skill that must be learned and nurtured. There's not a one-size-fits-all for everyone, and as oncologists, it's something that we train in during our training. We all go through a process of seeing our senior colleagues talk to patients, but also having formalised training, with actors to learn how to deal with different situations. So the most important thing is to ask your patient and their carers, what they want to know. You know, some people will come in with an Excel spreadsheet wanting you to fill out every little detail, and other patients will walk in and say, you know, whatever you think, doc. So that's identifying that from the start is probably the most important thing. Learning that skill is something which must be practiced.
I'd just also like to add, I'm not a clinician, so I'm coming from a different angle, but I'm kind of hoping that, well, whatever you tell your patients, whether you tell them everything at the beginning or just drip feed, they're probably going to leave overwhelmed and not taking in all the information. One of the first things they're going to do is go and Google it when they get home. And so that's where I think one of the benefits of a website like the Brain Tumours Online is that hopefully clinicians as well can point that website out to their patients and say, well, there's a lot of information out there, but at least everything on this website has like a signpost, it has content warnings, and it can be filtered based on your needs, and you know you can trust all the information that's on it. It's not just whatever anyone else put up on the website. So that's just another thing to consider.
If I can take the consumer side of things, thank you for what you do. You choose to do this. This is probably the most challenging job you could choose to do, so thank you from me to deliver this kind of information and the care for patients in this setting. I would suggest one thing that didn't happen for us that I think would have been more beneficial is for high grades, for example, because things can go wrong rapidly, is to include the palliative care team as soon as possible. Really, they were, you know, in the absence of any medicine, that clinical side of it was the most important for us throughout our journey. And because Josie fought for so long, we became quite good friends with them, and they're amazing people like you. And I think that can really help to navigate the family outside of the clinic, outside of the medical oncology part of the sphere, and direct them to more supportive care.
Maybe I can add something to this. Thank you very much. I think we now in the Netherlands we have organised that I'm not alone sitting in the consulting room with the patient. I always have my nurse practitioner or nurse specialist in brain tumor patients to communicate together with me, or as part of the palliative care team. So that's indeed very important. And I always ask patients, please bring someone with you, never come alone. And bring someone, take a recording of the conversation so you can listen at home again with your families, because indeed you're overwhelmed by information, especially if patients really think that they, well, would like to know all the details, that we're providing all the details, but most of it will not come to the minds during the first conversation.
I think from a nursing perspective, I think you do get better on this the more you do it. But also, I think patients and carers take in a very small amount at that initial consultation because of, you know, the shock and surprise that they're going through at that time. It's a completely different language. So I think allowing people time to take the information in, and social media or Googling's completely changed this whole sphere for us as well. But I think you've got to ultimately ask the patient and carer what it is they want to know, and it is coming back to information, allowing them the time to ask questions, and over time. So patients may go into a consultation, have that initial consultation, talk about that, but then they might ring up later or email later or want clarification on further things. So it is an ongoing process. It's not just a one-off time, I suppose. Okay, any other?
Oh, I have a question. This is regarding like genetic markers, but say like the initial like glioblastoma tumor, if it has like no mutations or whatnot, but once it reoccurs, can like the mutations change when a recurrence comes by? And like when can you like dictate when a patient's too weak for treatment, like with all these like new drugs that are coming out? So like I guess my question is like, when the tumour comes for a second time, can its mutations be different when the initial tumour had no mutations?
Thank you. You, Ben? Stuart?
It's unlikely that there's no mutations for diagnosis, maybe some missed due to biopsy or resection issues. Yes, the answer is yes. Treatment-induced changes happen, so radiation, temozolomide, changes the architecture of the genome. And of course, these tumours, I describe them as like suburbs of cities. So Sydney's a huge city, for example, but it's very culturally diverse throughout the city. You know, usually people migrate with people that they like, and so between each suburb they can have different populations of people, and these tumours are the same, and that's associated with the different regions of the tumour, where it's localised, where it's near immune cells, or whether it's near normal cells, whether there's vessels nearby. So they do change quite a bit, and so often what happens in a tumour is that we call them clones. Subclones kind of become dominant, and they're often the part of the tumour that's resistant to the treatment, and they'll become dominant, and then that will take over the majority of the tumour. So they do change.
Thanks, Matt. The only thing I guess to have to add to that is that this is historically been a challenging area to study when brain tumours progress. Often there's a limited window to sample that, and there are many international consortia trying to study this area. And that's another reason why some of the clinical trials where this sampling process and the surgery is built into the trial are so important. This is talking nationally and internationally. I'm not a scientist, but I guess it's not all about the genes. There's so many other different levels within the tumour that we don't know about. Sometimes we send the tumours off to for methylation profiling. I won't even pretend to know about some of the stuff that goes on in the lab to characterise these tumours. And whilst they are a challenging area for us to learn about, there's also hopefully opportunities there for treatment as well.
Did you have a question?
I was just going to ask Ben and Matt on that theme. Matt, you mentioned that some children do not respond to any therapies at all. That happens in I'm a cancer surgeon, so we've learned a lot from our gastrointestinal patients and cancers of our main primary, looking at that subgroup and why their genomes or their biochemistry is different. Has that happened in, I'm not au fait with DOPG, has that happened in your, and the other question I had earlier was to Professor, how common in the Netherlands is it for patients to have an advanced care directive? So we've tried this quite a bit in Australia, and people feel very shy to go there, whether it's the GP or the surgeon and the patient. And it's an ongoing education. But places like Oregon, 97% of their community has an advanced care directive before they're even sick.
In terms of the resistance to radiotherapy, I suppose I'll stick with standard of care. Yes, absolutely. Hypoxia plays a big role in resistance to treatment. Of course, localization of the tumour within the pontine region also, whether it's localized to critical nerves, means that radiation can't necessarily be directed towards the whole tumour. And of course, surgery is not possible except for limited biopsy. And we've just published a paper to describe some mechanisms of resistance to radiotherapy, but also to therapeutics and opportunities to reposition other therapies that tackle those resistance mechanisms.
Yes, as to your question on the advanced care directives in the Netherlands in brain tumor patients, I'm not specifically aware of the percentage. What I do know is that many patients go to their general practitioners because the system of general practitioners in the Netherlands is a very strong position, and they discuss the advanced directives. Well, as you know, things like palliative sedation in brain tumor patients and even euthanasia are frequently discussed with the general practitioner. But it's good to know. Well, it's important to know, I would say, that euthanasia is hardly ever practiced in brain tumor patients. due to the fact that most of these patients do decline and become unconscious, so are no longer able to express their wish that they want euthanasia in the end. But I would favor that also in the medical files in the hospital we are aware of this advanced care directives to prevent, like the patients that I presented, that doctors are aware that they have specific wishes.
That's one thing I just wanted to ask about, because I think on the 28th of November or end of November this year, voluntary assisted dying, or VADs, coming into this state. So it's been a bit of a discussion, but I think with the advanced care directives, a lot of the time in our practice, obviously, it's with the medical oncologists, GPs, but a lot of the palliative care doctors do a lot of the advanced care directives. But it opens a discussion, is really what it's about. And sometimes where you've got a patient and a carer that really don't know what each one is wanting. So I think it's very good for opening those discussions. But I wanted to know if there is that available in the Netherlands, and do you have any experience with that, with the advanced care directives or palliative care?
You mean that it's the information is open to all caregivers and to all healthcare professionals, so to speak? Because that's, I think, one of the problems that we see. If you don't communicate what you discuss in the hospital with the GP, it's no use, and the other way around as well. So you have to be well aware as healthcare professionals around one patient what exactly the status is of any advanced care directives. That's very important. And then again, it's very important also to realize that it may change over time. Patients are frequently willing to change their advanced care directive. It's nothing written in stone, so we have to realize this. And this is also, I think, an important aspect.
Thank you. Okay, right, we'll take one more and I think we'll then go off to lunch. Last question.
Thank you. Just with regards to tumour sample collection and at the point of resection, how are tumours stored in Australia, and with emerging therapies as far as vaccination, BioNTech starting to personalise this, discussion of storage of on paraffin versus frozen, and maintaining access to that for something that may come about 3, 6, 12 months down the track. And what is the practicalities of this, but also the costs associated, and when should the patient be involved in that step?
That's a great question and really pertinent to a lot of the things we're discussing today. The Australian Brain Cancer Research Consortium I mentioned earlier was one way we're trying to standardise those collection methods. By law, in standard care therapy, pathology, paraffin samples do need to be stored for a certain length of time. I don't remember off the top of my head, but it's sort of a certain number of years they need to be stored, so those samples will always be available in any case. In terms of fresh samples or frozen samples, that's more in the research domain at the moment, so that will vary from institution to institution. You may or may not be aware there are various biobanks around, some of them are institutionally based in particular hospitals, other ones are across research consortia. So for example, I'm only speaking about this because I know about in New South Wales, we have the New South Wales State Biobank, which some research samples are stored in, and some hospitals have individual institutional biobanks. So from a patient perspective, that's most certainly at the moment something which would be vary according to your institution and your caregivers, and as well as the clinical studies that you may participate in. So some of the studies have different requirements in terms of what we're trying to look at in those samples, and that affects how they're prepared. Hope that answers your question to some degree.
Probably the last question is,
and using our personal case, there was no discussions about this, and to my knowledge, that tumour sample has been kept exclusively in paraffin. So while that's good from a pathology and histology point of view, it doesn't give us access to emerging clinical trials. And we're hoping to kick this can down the road, keep our options open for as long as possible. Can that be implemented or integrated into the pre-surge or the post-surgical discussions?
Yes, I think just speaking to that, I suppose those sorts of things are very dependent on infrastructure, and that some of the national platforms are trying to look at addressing that gap, because having these samples available not only potentially helps the individual but also future patients. So that's a gap we're trying to bridge.
Okay, I think we might wrap it up for this morning's session. Please thank all of our speakers for their time. I think this morning's sessions have just been really good to open discussion and thought processes for patients and also for us as clinicians, carers as well. We hope that you can enjoy some lunch now if you can come back here at 1 o'clock. Thank you.